Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Hi, everyone. Welcome to episode 18 of the License to Lead podcast. For this episode, I spoke to Dr. Niran Al-Agba. Dr. Al-Agba is a pediatrician, and she's a writer, a prolific writer. She's got an op-ed column in her local newspaper, and she's written for national publications. In 2020, she co-authored a controversial book titled Patients at Risk. Dr. Al-Agba owns and runs an independent pediatric practice in Silverdale, Washington, and she's an assistant professor at her medical school alma mater, the University of Washington. She's married and has 4 kids, and I forgot to explain to Niran that it's actually not possible to practice pediatrics, run a business, write prolifically, and have 4 kids. Niran did her pediatrics residency in my neck of the woods at the University of Colorado School of Medicine, and then she went home and joined her remarkable father in his pediatric practice. Father and daughter worked together as physician colleagues for 16 years. Dr. Al-Agba the elder had grown up in poverty in Iraq, went to medical school in Baghdad, and ultimately immigrated to the United States for his pediatric training. When the elder Dr. Al-Agba died in 2017, the newspaper headline described this community father figure as irreplaceable. My guest, Dr. Al-Agba the younger, follows in her dad's footsteps. She's been named best doctor in her community repeatedly. Last year, she and co-author Dr. Rebecca Bernard published their book titled Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. This is a well-written, extensively researched book designed to wave a big red flag about patient safety driven by corporate greed. For instance, healthcare leaders whose biggest concern is profit will eagerly replace physicians with lower-paid personnel. And there's a glut of predatory online educational programs, making a lot of money for investors, but flooding the market with underqualified or unqualified nurse practitioners. In this episode, Dr. Al-Agba talks about the inspiration for the book, 19-year-old college athlete and straight-A student Alexus Ochoa-Dockins. Because we launched right into talking about Alexus, I want to provide some additional context here for listeners. Alexus Ochoa-Dockins was seen in an emergency department by a nurse practitioner who had trained in an online family medicine nurse practitioner program. She had 0 training, which would have equipped her to even see emergency department patients, and yet she was staffing the emergency department alone. Alexus died, and her story inspired Niran to co-author this book. These issues directly link to the values and the expertise and the ideology of those who lead medicine and lead healthcare. I dive into all of these topics with the irrepressible Dr. Niran Al-Agba. Hi, Niran. Welcome to the podcast. Thank you for being here.
Hi, thanks for having me. I'm thrilled to be here.
You have written this book and you've launched a podcast. Both of them are titled Patients at Risk. And I definitely want to understand the subject of your book and the important link to physician leadership. But right off the bat, if you could just take a minute to talk about what it was like to join a practice with your father.
Sure, it was amazing and challenging, and I learned a lot all at the same time. You know, it's one thing to talk about it when you're growing up and you sort of talk with your parents like any kid. You know, you sort of have dreams or things about what you want to do. And my dad, I think, first of all, he didn't think I should be a pediatrician. He thought I should pick something, quote, easier, where you didn't have as much call, maybe after hours. I think he was more excited about dermatology or radiology, just because I could be home a little more potentially or have a family. And so he would say, don't go into pediatrics. And then as it got closer and I, matched in residency, I think it became more of a reality for him. And so then he started really talking about, wow, well, when you come here, well, before you join me, though, you should come for a month and work with me. So I came and we had a great time. And then it just felt like the right thing to do. And of course, I learned a lot from him. He probably learned a little from me over the years, and it was a really fun balance. And he used to say, gosh, he's a male, I'm a female, so we had that covered. I was newer, he was older. I just had a resident say that I was older and he was newer when I was working with a resident. So now it's come full circle, of course. But it was really what I love about medicine, which used to be taught in an apprenticeship format. And so I really got to experience that. Even after 11 years of schooling, I had 16 years to apprentice with an expert.
I think it sounds like a dream come true. It was probably especially good because you were right out of residency, but anytime we work alongside somebody that we respect, it makes for such a great work life. And didn't you spend a lot of time in your dad's practice when you were a kid?
Yes, it's amazing because he sort of said one day, I was about 9 or 10, and he said, I'm going to work on Saturdays and I need somebody to book appointments and, answer the phone. And I'll pay you to do this, and then I'll take you out for a business lunch afterwards. The name of the restaurant here in my town is the Boat Shed, one of my favorite places to eat still. And I always think back to the lunches that we had there. And I remember some of the patients when I'd answer the phone, I'd say, come now. We had an appointment book. You would write in pencil on the appointment book and they'd say, are you his daughter? Who are you? And so a lot of these families remember me answering the phone. And then I kind of did every other job all the way through high school. I balanced the ledger back when we had the carbons, and some older doctors listening will remember billing in those days where, you ran the carbon over their name and you could hand it to the patient. I was the janitor my junior and senior year, and I cleaned the office every week. I've done every job almost from start to finish.
That is the ultimate apprenticeship.
Yeah.
Is there ever kind of a supremely awkward moment or maybe a poignant moment when you disagreed with your dad's management of a child or of the business?
I would say the business, because I think when I joined him, he hadn't really thought about turn it into a partnership or what should we do. And I had to push him a little bit. When you go from a sole proprietorship to a partnership, you have to start the business over, kind of. I think he didn't want to really do that. But I had said to him at the time, what if something happens to you? You're in your late 60s. I want to be able to keep going. And he didn't want to think about his mortality. So it was the one kind of difficult place we had. And my mom stepped in to try to help navigate it and pushed him. And what's amazing is that's what happened, right? 3 years ago, after 16 years of working together, he suddenly died. He hadn't retired. He was still working. And I did not have to close the business. I kept going. And even ironically, to tell you, yesterday, TRICARE's made some changes. And the guy on the phone said, you have to do a new contract if the doctor died. And I said, no, I don't. I'm still the doctor who signed the contract in 2002. I don't need to terminate a contract and start over.
Right.
But I have a favorite story about when I came to join him, which is kind of fun.
Yeah, go for it.
He used to tell me when I first got there, don't come and ask me dumb questions because you want people to think you know what you're doing. And remember, by this time, I'd had 11 years of training to do this job. We had a kid in, and my dad's assistant at the time said, we just draw his blood. We check these different levels, calcium and thyroid levels, et cetera. And my dad was on vacation. And I thought, wait a second. And I asked this kid, did you have a heart defect? And he said, no. In fact, he did. And when I put it all together, I said, well, I think this kid's got velocardiofacial syndrome. And this is a genetic disorder. And I called my dad. I didn't want to step on his toes. And I said, hey, there's this test you can do for this abnormality on the 22nd chromosome. He said, oh, well, that sounds exciting. We should do that on this kid. I called the family, explained it all, and did it. And it was positive. And so what was fun is after that, we sort of had this, I would say, a more balanced kind of relationship in that there's a lot I didn't know, but there were some new things he didn't know. And it was a lot of fun working with him.
That is such an interesting pivot point in your relationship with him.
Yeah.
And I love your point also, which I can so relate to and so remember. We're always learning, but it's really a steep learning curve even after all that training.
Yeah, it is. And even after he died, sometimes I had a couple cases that winter that I just wasn't sure what to do. And one of the dads looked at me at some point in, a few months after he died, and he said, it's really hard without parental supervision, isn't it?
Oh, that's funny.
He knew because he'd lost his own parents. And I just said, that's such a good way to put it. Right. After 16 years in practice, 11 years in training, I still felt like I should have some supervision.
I think that we like to get help and like to collaborate and like to get other people's opinions. But you're right. It can feel a little bit lonely when you realize you're the expert. You're the one.
Right. All of a sudden.
Yeah. Let's talk about your book, Patients at Risk. Your book is really focused on issues related to primarily independent practice by NPs and PAs, nurse practitioners and physician assistants. And it's kind of a gripping read. It's really fascinating. And I wonder if before we do the deep dive, if you could talk about why this book at this time. You published this last year, you and your co-author. Why now?
It's two things, really. I should credit Rebecca. Rebecca had called me, and she also was another physician writer, and said, I want to write this book on this subject. It's something I care about. And we're both in independent practice. So we were able to do it without getting fired, which most doctors probably would have been fired if they'd written this book. She said, you're the only person I can think of who could do this with me and stand up to the fire that's going to come back at us. So I thought, I feel just as strongly as she does about patient safety. So we kind of embarked on it. And then I found this story, this court case for the Alexus Ochoa-Dockins estate had settled for $6 million. Alexus was 19 years old. I have a daughter. I know you have a daughter. I think sometimes we put ourselves in the place of someone else, another parent. And I think I stayed up all night reading her story and reading so many depositions. And I just thought, we have to tell her story. This young woman should never be forgotten. She deserves to have the country hear her story, so her death is not in vain.
Right. And you dedicated the book to her, right?
She inspired it. I mean, at least for me, to get this published was so difficult. Nobody wanted to take this on because it's such a controversial subject. She kind of inspired me the entire time. I just kept thinking the world needs to hear Alexus's story, and I'm not going to let go of it until I can get to that point.
When I read the book and read your introduction and the dedication, the fact that you referenced the corruption and greed that has led to some of these outcomes, I think that's what really snagged me, because that is so much a part of the business school mindset, I call it the BSM, that has been gripping healthcare. It sounds like it really played out in this instance.
Absolutely. And so many people have made this debate, the debate about non-physicians working independently in healthcare. So many press and politicians and people that aren't involved directly in healthcare make it about ego. They say, oh, you must profit off of holding people back, or you must gain something out of being just the physician leader and not allowing anyone else to come into this space. And it's never been about that. I mean, I've got a full practice. Rebecca's got a full practice. We both have waiting lists. We're not at a loss for anything. And I'm going to be needed in my community forever, probably. So for us, it's about patient safety. What's happening is it's the business people. It's the corruption of the hospitals and the large organizations that are saying, hey, look, do we need to pay for a doctor? I mean, patients don't need doctors, right? I mean, a nurse or a physician assistant is just as good. So let's just kind of sell this idea. And we found a lot of nurse practitioners and PAs don't want to even be independent. If you think about it, the story I was talking about working with my dad, here I went to 11 years of school. I did 16 years working with my dad, and I barely felt able to run my own practice. And I'm not talking about the business. I understood the business part, but there's still so many new things I see every day. And I think that's what gets lost. People aren't widgets, and a widget is just a unit of something. It's a piece of packaging, or it's a thing you're selling. And so they're looking at healthcare as either selling widgets or serving widgets, and they don't really think about them as people. So they figure, if I can pay a nurse practitioner less than I pay a physician, and they can still kind of get these widgets through, and maybe a few die, but gosh, I guess that's the price of doing business. And that's their mantra. Whereas most physicians are thinking, I don't want anyone to die. I don't want anyone to make a mistake.
Right. It's really putting patients first. It's not putting profits first. It's really this ideological divide, I think, between the business school mindset and the professional medical mindset.
That's right. The business school, you can't give people that just have an MBA the medical mindset. You can't do it. They don't understand. Right. They're thinking in widgets, not in humans.
I have to confess, Niran, that when my daughter, Jamie, worked with you as a fourth-year medical student, and she's
amazing.
She gave me your book, and she thought it was important and that I should read the book and talk to you. Even at that point, before I read your book, I was inclined to pedal backwards as fast as I could away from this topic. And it's just what you were saying. It's that idea of physicians who are concerned about independent practice of non-physicians. It's the idea that it's a turf war, that we want it all to ourselves. Physicians don't want to get that stuck on us. That's icky. And, we just want to run away from it. So you really have demonstrated courage by tackling this. And I understand that so much better after having read the book. I think physicians, because it is a patient care issue, and we'll get into it a little more deeply here, we're really obliged, I think, to behave like you have and like Rebecca has and take a stand and understand the issues.
Well, thank you. I've been shocked by the number of physicians who've kind of reached out over time and just said, I had no idea. I didn't realize these studies were not being really looked at closely, and they were being kind of twisted in the media. And we had no idea in the difference in training. And what's amazing is many people have asked, well, why did you write the book? And for me, I wrote the book to share with patients. I'm so thrilled doctors and other healthcare people are reading it, but I really wanted the public to read it because I feel like nobody else is standing up for them. Politicians are not. I've given up on politicians like completely. The different lobbies, the hospital lobby is too strong for me to fight against. So the way I look at it is if I arm patients with information, then they can make a choice. And that's probably the most important thing to do for patients to keep them safe.
Okay, I had no idea that really was your underlying purpose with the book. You definitely make the point in the book that one of the most important elements from your perspective is giving patients the information that they need to make things more transparent, to arm them with some language that they can use to find out who's taking care of them or taking care of their loved ones. But I didn't realize the book actually was pointed at patients.
Yeah. I've learned over the years in my own practice, what I'll do is, when you send someone to a specialist, sometimes the specialist doesn't really know what I'm looking for or what I need. So I will often prep them like a deposition would do for a witness kind of. And I say, okay, these are the 3 questions I want answered. You can have whatever questions you want answered, but you got my questions, and I give them on a Post-it. And it's really cute because the patient knows what to ask, and then the patient knows what I'm concerned about. And then I think we get a better visit from specialty care. So I've learned to really trust my patients to make the best decisions for themselves. And even if I don't agree with their decisions, I often say patients don't agree with me half the time, and that's fine. If they know an opinion and weigh and measure for themselves, then they really are happy with the outcome. And so it's the same thing here. So let's just arm the patients, because that's worked out so well over the last 20 years in practice. I just need to trust that people will read it and understand and then be able to help themselves.
Super. Well, we have been talking about the book. Let's dive into the content, and it might help if you could clarify the difference between the PAs and nurse practitioners. I know that you discuss both of them in the book.
Sure. So the education differences, let's start with nurse practitioners. In general, you're supposed to be a registered nurse with a bachelor's. Now, there are a number of pathways that you can go. You can go from not having a bachelor's to having a master's degree. It's called a direct entry program. So there are a variety of ways to go from having an associate's degree to then getting that master's degree in nursing. But the standard way is to become have a bachelor's in nursing, and then go to anywhere between 18 months to 2 years of additional schooling. And then you can become a nurse practitioner with a master's degree in nursing.
So you'd be an RN, typically you'd be an RN and then do another 18 to 24 months and become a nurse practitioner.
And you have to get 500 hours of clinical care to then qualify.
A minimum of 500 hours. And you mentioned the direct route. So are you saying that you could be an accountant and then become a nurse practitioner?
Yeah, so you could be anything. You could be an accountant, you could have a philosophy degree, you could have no nursing experience whatsoever. And then you can go into these direct entry programs. You have to do the prerequisites to have some nursing education, and then you can basically have your master's in nursing and go right out to work as a nurse practitioner.
So I understand some of these programs are almost exclusively online with very minimal patient contact. Is that possible?
Yeah. And, many of them, you sort of go to the school for a week or even a few days of classes. Then you do everything else online. And then at the end, you'll go in for sort of an ending project, nursing project before you graduate. And even the doctorate programs are the same way. So after, there's another group that can go and get their bachelor's in nursing and then go in for 3 years and graduate with their, quote, doctor of nursing practice. And then they can introduce themselves as a doctor.
Okay. I've never heard a nurse practitioner introduce themselves as a physician, as a doctor.
You will hear it. They do a lot, introduce themselves now as doctors. Not a physician. They can call themselves doctors. And so that's where this gets confusing. And according to Alexus's mother, who was there that night when she went into the ER, for example, the mom said she introduced herself as Dr. Thompson, the attending in the ER that night.
Yikes.
Yeah.
Could you give more of a picture of what happened with Alexus?
Yes, she's a 19-year-old presented with very clear signs of what's called a pulmonary embolus, which is a clot in the lungs. And probably if she'd been diagnosed within even the first 7 to 8 hours, she would have lived. She was not properly diagnosed until about 13 hours later when she arrived at a different hospital. And unfortunately, she died within an hour of arrival to that care center.
Okay, and we'll come back to all the underlying issues there. Niran, would you talk about the PA education?
Sure. So usually they do a college degree and then a generally 3-year program after that, 2 to 3 years. They have to have 2,000 hours hands-on clinical experience in order to get their license. But now there's a new program called a Doctorate of Medical Science. And so PAs can now introduce themselves as doctors as well. They will be getting independent practice across the country over the next few years. So I think it's North Dakota where they can practice independently. And Washington State, my own state, is trying to allow for physician assistant independence. Despite the name physician assistants, they're trying to say, no, just shorten it to PA. And that means I'm your provider.
Okay. I know you love that word provider.
Good Lord, I'm so not fond of that word.
So you mentioned that nurse practitioners have a minimum requirement of 500 hours of patient contact time, and PAs have a minimum of 2,000 hours. And can you draw a comparison with physicians?
You bet. I had 20,000 hours because I trained before the residency hours were changed. But today's residents that are graduating, even with the residency hour limits, they have 15,000 hours of training when they finally get to practice independently.
I'm sure I was in the 20,000 hour department as well. And I just have to point to how both of us were reminiscing about coming out and still feeling like we had a lot of questions to ask and a lot to learn. And isn't that a little paradoxical? I mean, what do you make of that?
That's, to me, the largest piece of it. You know, here we had all this knowledge, all this training. And I mean, I have seen stuff in residency I've never seen again, yet it's burned in my brain, or I had to go through that process. And yet I still doubt myself. I still just want to be extra careful, or just want to think about every tiny little possibility of what could go wrong. We write about it in the book. There's this Dunning-Kruger effect, where once you are an expert and you have that 10,000 hour base to be considered an expert or having expertise in that field, you are appropriately humble. And the idea of Dunning-Kruger is that when you're first starting out, and residents and medical students have this as well, where they think they're right until they make a mistake or whatever it is. The difference is that med student and that resident, they're not practicing independently. They're reporting to an attending. They're overseen at every step. You know, you can't do anything completely on your own. And yet at the 2,000 hour mark and at the 500 to 1,000 hour mark for nurse practitioners, they're out on their own independent. Nobody overseeing them.
Right. I have a section of my newsletter that goes out with each podcast, and one section is called Big Fat Opinion, BFO. And I wrote about the Dunning-Kruger effect because the guest that I'd interviewed talked about how he had less certainty now that he'd been practicing for 20 years as an emergency medicine physician. And he quoted a radiologist who he said was a fantastic radiologist. He said, I can't even read a chest x-ray anymore. He's seen all the possibilities, all the variations that can snag you and that you have to be worried about. And you get to the point where you realize that you're a learner all over again. And it is really disconcerting to think about people coming out confident of what they know after 500 or 2,000 hours, confident to practice independently.
Well, and two words that I find really important in what you said were confidence and certainty. So there is no doctor worth their weight in gold that will say, I am certain of XYZ. Well, okay, doctor, is it this way? And I'm like, well, yeah, it's probably this way, but it could be this, and this. You know, you're always thinking what else could be going on. And again, I'll have days where I'm thinking, you know what? I got this. I understand medicine after, 27 years of working in this field. I'm pretty okay. And then something comes out of the blue and blindsides me. And I think, well, yeah, forget that. I'm back to the drawing board. I don't know anything about what I'm doing at all.
It's really expertise. It's the expertise of understanding the foibles, the fallacies in the research or in what we think we know.
It's interesting how comfortable some people that aren't physicians are just sort of saying, well, I didn't know that, so I guess that's too bad. We got called recently. Some of the lawyers around the country have reached out to either Rebecca or I to do kind of expert testimony. And I looked at a case, without going into too many details, where it was something that got missed in an urgent care. And the nurse practitioner said, well, I wasn't trained to diagnose that. And that's such a foreign thing to us. So let's say it's just an infection. I wasn't trained to diagnose that infection. And it's like, well, wait, you're in an urgent care. You should know the whole body and every infection that can happen, at least enough to make sure the patient has what they need. And it was sort of this idea of throwing up my hands like, well, I wasn't taught that. I just don't know of any doctor who thinks like that.
If you put that up against the fact that they want to be an independent practice, but feel comfortable saying that nobody taught me that, so it's not my problem. To the extent that they say that or feel that way. And we're going to have to frame this in terms of the individuals who want independent practice versus those who don't.
Right. And there's also this group that is willing to do independence at an urgent care when they've been trained in primary care. So there are a lot of great non-physicians who were trained, let's say, in primary care, or nurse practitioners trained in primary care who are then out working in primary care with supervision. I mean, that is a great model to really work as an extender to us. But for example, Antoinette Thompson, who is profiled in the book, she did an online family nurse practitioner program and figured, I'll be fine working in an ER by myself.
An ER, not an urgent care.
No, an ER, a major ER. And she was alone with no physician to supervise.
Yeah, it's such a compelling story, Niran. She really didn't know the diagnosis, and it was pretty classic. Somebody that had all the reasons to have a pulmonary embolus.
Right. What made that story so fascinating is when you combed through the depositions, and obviously some people might have to read the book to follow this part of it. They'd put a nurse practitioner who was an expert witness on the stand and asked her to do a differential diagnosis. And her name is Wendy Wright. She actually has a career all across the country being a star defense witness for nurse practitioners when things go wrong. She couldn't do a basic differential. And they put this other doctor, Dr. James Leo was his name, and he's a critical care physician. And he narrowed it down to about 3 diagnoses. He started with a list of about 10 that were all made sense. And then he said, well, if you did this study, now we're down to 3. And I would just do this other study and we'd have an answer in about an hour. It's so different in the approach. And that approach led to this girl's death. I mean, the wrong approach essentially killed this girl.
I think that that's the most intriguing part of your book is enlightening all of us. We go to medical school. We don't really know how we're absorbing this information necessarily. We don't have anything to compare it to. And in your book, the way you go through the fact that we look at a broad range of things and pick through it and rule things out, and you just narrow it down and then do the appropriate number of tests. And do you have a way of contrasting that with what seems to be nurse practitioner or PA training?
Yeah, I think, first of all, they don't have the background or the broad training to be able to do a real differential diagnosis. I've still never found a non-physician who can do that differential diagnosis. I think that's what takes the 10,000 hours. And so what they often do is, oh, it hurts to pee, so it's got to be a urinary tract infection. So they kind of go, then they'll do that one test. Okay, it's a urinary tract infection. That's actually the number one misdiagnosis that I see coming out of urgent cares in my hometown. And the difference is, essentially they'll go with it, even though it doesn't make sense. Like, let's say the urine is clear, but they say, well, it hurts to pee. What else could it be? Well, goodness gracious, it hurts to pee. Well, it could be a kidney stone. It could be an obstruction. It hurts to go to the bathroom if you have a sexually transmitted disease. It hurts if you have appendicitis. I mean, I could go down this huge list of things that could be, and they're not thinking about those things. One of my favorite stories is a mom who came in. In fact, they were just in again recently, and their daughter said, "You're the doctor who saved my life." And I appreciate that, but they're giving me too much credit because they went to 3 different urgent cares and were routinely diagnosed with a urinary tract infection, even though the urine was clear. And then she developed a rash on her lower extremities and buttocks area. And I remember the day her mom came in and she kind of had her arms folded and you could tell she was frustrated. She said, I've had enough. I've seen 3 different doctors. No one can tell me, but now she's got this rash on her lower half. I literally said, okay, well, take down her pants. I felt on her legs and her legs had these purple circles that we call petechiae or purpura, and they were lumpy, which means they're now palpable, which means we can feel them. And I said, oh, she's got Henoch Schonlein purpura. And I'll never forget the mom's mouth opened and she goes, wait, what did you say? It took you less than a minute. And I said, well, that's 15, 20 years of training. That's the difference in education.
In the book, you talk about starting with the symptoms and going down a rabbit hole is more of a tendency if you don't have a rich foundation in the science and haven't seen some of these diseases or problems in the middle of the night or in the emergency room or in the various rotations that physicians do on the way to getting their MD or DO.
But you don't even need to always see it. And I'll tell you one short story. Well, I'll try to make it short. It was an adult who came in, and I don't know anything about adults. And I didn't realize a retropharyngeal abscess is it is an emergency with children, but children live. So apparently a retropharyngeal abscess is a really serious thing in an adult. They can get even sicker. They end up in the ICU. I had a mom come in, her face was swollen. She couldn't open her jaw. I honestly have no problem admitting to you, I didn't really know what she had, but I knew her symptoms were bad enough. I was like, something's wrong. I was seeing her baby who looked great. And I looked at her and said, do you mind if we see you? Something's wrong. And I ended up calling my friend who was an ENT. He said, oh, goodness, get her on the ferry, get her to Seattle right now, get her in the hospital. And I can talk about it. She's given me permission. She told a lot of our town. But again, I honestly didn't know what was wrong. But there were enough symptoms that made me say, something's not right here. It's not just a cold. And she had been seen 24 hours before.
And it's that tacit knowledge, too. It's knowing sick when you see it.
That's exactly what it is.
And having this low threshold to reach for help. And that is such a huge part of the practice of medicine is asking for help, consulting somebody, running it by the specialist. Could you dive into a little bit about it seems like a hot button topic around research. There's research that's cited by folks who really would like to see NPs and PAs have independent practices. Can you talk about that?
Sure. I really didn't realize it when we started writing the book. You look up on Google or wherever, they'll say physician assistants and nurse practitioners have the same outcomes as physicians. Therefore, why aren't we letting them do the same job as physicians? That's the mantra that these lobbies, especially the AANP, the American Academy, I think, of Nurse Practitioners, they're pushing this idea that the care is the same. So why aren't we the same? And what's interesting is they didn't do a statistics class. They didn't do a research class because even on their websites, a lot of their research misquotes the papers and misuses even the concepts. So in reality, when we looked at the Cochrane database, which has the 18 studies that everybody's touting prove the care is the same, none of them had independent practice. No randomized studies have ever evaluated independent practice of non-physicians in healthcare. Yet they're touting they're the same. The truth is they are the same with supervision, meaning if I'm a rheumatologist, this was a great study, and I have a nurse practitioner working with me and I treat you, as long as you get seen by the nurse practitioner in 6 months and then you see me again in a year. So the nurse practitioner does the follow-up, the stable chronic condition follow-up. Absolutely no patients are harmed. But that study is not saying go open your own rheumatology practice and throw caution to the wind.
Some of the studies that are cited as demonstrating equivalency, NPs and PAs actually were in a supervised relationship with a physician. So a physician was supervising them.
Yes. And again, even there's one that I call it like tries to be independent. And it was the one done in New York, actually, at Columbia. And Marymundinger is a well-known researcher. And she really, I don't want to throw her under the bus here because she saw the shortage of physicians and thought nurses could fill the gap. And I think her theory is right. And I don't think her goal was this nurse practitioner independence. And what she did is in New York at that time, it was illegal to work independently. So they recruited nurse practitioners. They did a mini residency for 6 months, extra time in cardiology, radiology, et cetera. All of the nurse practitioners in that study had a doctorate or a PhD level of education, and then they tried to compare them head to head with physicians. And so again, they were still supervised. They couldn't admit to the hospital on their own. They had to have a physician co-sign their notes when they were bringing a person into the hospital. So it was a supervised study, and yet they call it independent. To me, that's, really not the most appropriate way of doing research. And of course, the Journal of the American Medical Association printed it. So they sort of bought in hook, line, and sinker. And again, it's a wonderful study. It's in my opinion, it's one of the best studies done in the US, but it's absolutely not independent. So again, they can provide great care when supervised by physicians. That's it.
Right. I can quote you here, quote, "There are absolutely no credible scientific studies that support the safety and efficacy of non-physicians practicing without physician supervision. None," close quote. Many of these studies were done to make sure that nurse practitioners and PAs, that using them in conjunction with a physician, with physician supervision, that was safe.
Yes. And actually the first study, the best study that was ever done, is my favorite one to talk about. It's the Burlington randomized trial. It was done in Canada. And we had 2 family docs who were at their capacity for what they could take as far as patients. And so they had these 2 wonderful experienced nurses. They said, isn't there stuff we can teach them to do the chronic condition follow-up? So those nurses went back to school for about 9 months. They developed a program for them to teach them how to do kind of more chronic care. So what's amazing is they came back, they did a really cool study and found that it increased their capacity to accept new patients by 22%. With not a single person being harmed. And it became kind of the talk of the area in Canada, look at what these doctors are doing. They're having these nurse extenders. To me, that is such an amazing idea. It's really innovative. It's everything we want to see in healthcare. And then it's, of course, this beautiful thing that was created has now gone sideways. Now we've got people working in urgent cares. They're working in ERs alone. The original part of this was to extend primary care, so everybody in America had a primary care physician that they could identify with and they could see. And obviously greed, corruption, wanting to have higher pay, et cetera, has kind of turned it all on its ear.
Yeah. Let's come back to those connections to business outcomes and to increasing margin. We'll put a pin in that for a second. I think it's important to talk about how much we love working with nurse practitioners and physician assistants. I loved working with them. The other physicians who I worked alongside really enjoyed having nurse practitioners and PAs on their teams. The original idea was, as you said, extending the practice so more people will be served, more patients can be seen, and there are physicians involved who have this great depth and breadth of education.
And I'm so glad you brought it up, because I do. I have a pediatric nurse practitioner I work with, and she's amazing. She went to a brick and mortar school. She worked as a nurse before she went back to do pediatric training. And again, she would tell you she was trained to do primary care, but obviously kids come in with head injuries, kids come in with various things going on. And what's been great is she said to me, look, I'm not sure I want to work independently. I love having someone to talk over cases with and to learn from. And if you ask her about her first year in practice, she's going to say, oh, I learned so much. I read so much. And there's nothing wrong with that. So I love the idea of collaboration. I love the idea of teamwork. I don't love the idea of forcing nurse practitioners to be, quote, supervised from afar. So the one struggle I have is some of the states will say, well, a doctor can be 150 miles away and a nurse practitioner can have this practice. And as long as they sign off on the charts, we're going to call it good. And that isn't collaboration, in my opinion. Dr. Nurse Nikki and I, because she has a doctorate, so that's what we term her by to make it clear to patients. She'll tell them I have a doctorate in nursing. I'm not a medical doctor. And she and I share overhead, essentially. I don't, charge her to supervise her or charge her to collaborate. I kind of feel like that's what we do in medicine. We give back, we teach, we work together. And I've learned things from her too. I would never say that I know everything. I love when she thinks out of the box. I learn something as well. And she's always willing when she doesn't know to come in and talk to me about it, because she doesn't want a patient harmed either. I think it really can work, and I think it can work really well. I remember when I told her, when she came to work with me, I told her, look, I'm writing this book. I don't feel right bringing you into this situation without telling you first. And I told her the story of Alexus and what happened. And the first thing Nikki said to me was, That nurse practitioner did not belong in an ER on her own.
Right.
I would never take a job like that. I was not trained to do that, and I need to recognize my limits. And I don't think I could have said it any better than she did.
Right. And to be promoting the idea of independent practice of people who don't have the breadth and depth of knowledge to be able to do that competently is throwing them under the bus. I mean, what a horrible situation to be in. Some of these programs are predatory programs, predatory online educational programs. They're not thinking of what's going to actually work for this individual's career or what is a legitimate amount of training to have. They foster the idea that you can come here, take this online training, get 500 hours of FaceTime with patients and go be independent. And it's terrifying to think about being that individual in that situation. And if they're not terrified, I'll be terrified for them.
Well, we are terrified. And that's why we wrote the book, because we thought, people need to know, and they're being sold a bill of goods. A lot of these nurse practitioners will get out on their own and say, oh gosh, I'm not ready for this. They get sold a bill of goods like, oh, you're like a doctor. I mean, 500 hours, who needs more than that? And so then they get out and somebody dies or somebody has a bad outcome. Even when we talk about immunizations, I remember Nikki and I were talking early on, and I said, you have to know everything. You have to know every immunization, what it looks like when you give it. You got to be the expert in the room. And she said, wow, we got no training. We were just told, oh, the medical assistant will give the shots. And I said, it's not the way it works. You got to know everything. And she's done the work. She's learned. She knows immunizations backwards and forwards now. But her schooling, her pediatric nurse practitioner training, her doctorate in pediatric nursing practice did not teach her that. I did.
Yeah. Well, there would be so much like that. There's so much to learn.
Mm-hmm.
So, Niran, do you have any idea what percentage of non-physician practitioners want independent practice versus those who understand their limits and very much would appreciate having supervision?
If you'd asked me before the book was published, I would have said maybe it's 50-50, but I was very wrong on that. I think it's more like 80% do not want to be independent and on their own. It might even be closer to 90%. And that remaining 10 to 20% that are very young, have really not a lot of hands-on nursing experience, and maybe were the accountant before they went back to get their nurse practitioner degree. Those are the 10 to 20% who really think they're equal to doctors and can do everything we can do. So it's a minority.
Yeah. And that's so important. I wish that I would have asked that question right at the beginning, because that does truly help frame it. And I think also reflects the experience that most of us have had who have worked alongside PAs and NPs and so appreciate them.
Right. And it also reflects the integrity of our nurses and our physician assistants in the country, right? Nursing is an amazing profession. My grandmother was a nurse. Both of Rebecca's parents were nurses. I have the highest respect for nurses that any physician could. This isn't about not respecting the nursing profession. And the nurses who worked in the field and choose to go back to school and get their degrees, most of them have a high amount of integrity. They work very hard. They're very clear on the roles. So it's really an excellent point that even I learned after writing the book. It's the national lobbying organizations like the AANP that's really attached to this idea of independence. And it's most nurse practitioners, honestly, with boots on the ground that would say, no way. I want to work with physicians. I want to be respected and I want to be treated properly like anyone should.
It seems like there's such an incredible head of steam behind the public relations for the idea of independent practice. And that belies this notion that perhaps a majority of non-physician practitioners, a majority don't want independent practice. They would prefer to have excellent supervision. Where is this steamroller of public relations coming from, do you think?
Well, it's really interesting because I know it's partly the American Academy of Nurse Practitioners. I think they really were unhappy with the book when it came out. Obviously, their president, Sophia Thomas. Again, and I don't know, but I suspect since she brought up profit, she tried to bring up the fact that she thinks Rebecca and I were profiting off of holding back non-physicians from working independently as being some way of profiting from it. So I suspect she's motivated by profit. I mean, she leaves me with that opinion after watching her reaction. It's all about money. I think there's a huge profit-driven piece to this between the American Hospital Association and then the nurse practitioner lobbying organizations. And what I found in a lot of the commentary following the news segment that ran in December on the WGN network, it was their number one video ever published, actually, in the entire history of the news organization. Now it's only been around for about 3 months with the most views. And the thing is, what I found is that Sophia Thomas really wanted this independent practice, and so many people disagreed with her. So many nurse practitioners commented, I don't agree with those ideals. They even said things like Dr. Al-Agba saying nurse practitioners are great to work with did us more justice than this sideways approach to wanting independent practice. And so I think it's probably got to be motivated by money, since that's what she concentrated on her press release against us. That's the only thing that makes sense to me.
A tendency there to accuse you of perhaps what is motivating her, is what I'm hearing.
I think so. I think a lot of times when the different lobbyists or the head of these organizations will leave, and Marymundinger is another example, she left the Columbia nursing program and went on to sit on the board of United Healthcare. She got $70 million out of that deal. And I mean, we're talking about money. I'll never see that kind of money, which is fine. I don't need that kind of money. But I suspect the president and the leaders of these nurse practitioner organizations who are fighting for this independence, and really they're fighting for legitimacy of a profession. They're fighting for it to be equal to medicine. And so they have a tall order, but if they do it, there's a lot of money on the other side. Healthcare is big business, as we've talked about. And it's people that are heading those organizations, and they're selling goods they can't deliver. But by the time you need to deliver it, the damage is done, and they're sitting on the board and they're pulling in their 70 million.
Right. I think it is so important for us to understand this issue and have opinions, and especially now recognizing that perhaps the majority of the non-physician practitioners understand that supervision is a good idea and that their training is different from physician training. And isn't there a bit of a bait and switch here also with the idea of saving money and also the idea of serving underserved populations? And how has that actually played out?
It's so interesting that it hasn't helped really much at all. So the idea was, let's train people that are physician replacements, and then they can go out into small communities and work, independently. And that's going to change access for everyone. And at the same time, they'd say, well, it's going to lower cost. And so when we looked at the studies, even back to 1974 is one of my favorites that I found early on. And the cost was astronomically higher because the nurse practitioners tended to do more studies, more imaging, more EKGs, more urinalyses. We don't really know why, but the researchers surmised that it was they wanted more information to make decisions because they didn't have that experience to rely on. And so I think that is a huge part of it. And most studies have shown, the cost difference in the amount of studies they order, in the referrals they do, again, it just increased healthcare costs. And the second problem is, I got to be honest with you, I'm in a rural area or at least an underserved area, medically underserved. I do a lot out here that I don't think a lot of doctors get to do, larger, more metropolitan areas. There's no plastic surgeon on call to sew up the child. I sew on faces. I've sewn up big, deep wounds. And that's just a daily kind of thing for me. And I see head injuries. I kind of run like an ER because there's no pediatric specialty ER here. I'm the best we've got.
That's disconcerting because a lot of the support for independent practice authority is based on the idea that they're going to provide care in underserved or rural areas. And that's not really happening. But you bring up this great point that a more remote practice like your practice, because it's the only show in town, will be more demanding medically. It's got a bigger scope because there's no children's hospital around the corner.
That's right. And that's what I find so interesting is this argument that legislators make saying, we have no access in rural communities. So let's give people 2 years of education. Let's just send them out to kind of fend for themselves. And what I find so interesting is I really do everything. And there are physicians that I talk to all the time that say, gosh, I haven't stitched or sewn a laceration in so long. And I do it every week. There's no plastic surgeon. There's no, there's no ortho. Let's see, I just had 3 fractures today. It's like running an ER. And I think what's so interesting is people forget that in small communities, you don't just say, well, you have a laceration, go to the ER, go to the children's hospital. So now you've got people that are less trained than physicians, and they're going out into small communities. And a lot of times they don't have this extensive training. And I think that's a shame because we really need the full spectrum of training when we're out in a small community.
That is just so much the opposite of how things are really spun in order to support the idea of independent practice authority.
Well, I love that you're saying spin because that's exactly what this is. It's let's massage the argument. Let's massage the square peg to fit in the round hole.
When you hear that somebody has a doctorate in nursing, that sounds like a lot of education, and you would assume a lot of clinical training. What does that doctorate actually look like?
It's really interesting because even I, until we really got into the research in the book, thought that a doctorate meant that they were doing more of a PhD type level education. Doctorate of nursing practice sounds like it would be that. And of course, there are PhDs in various nursing fields, biobehavioral nursing, nursing leadership. So there are PhDs, but doctorate of nursing practice, to a certain extent, is honestly just trying to have the name doctor. And that's what's the shame in it is it's a couple of courses. If you look at them, they're on clinical leadership, nursing in today's world, politics of nursing or nursing in healthcare policy. A lot of those that are in the nurse practitioner field are saying these are not really clinical degrees. These are more administrative degrees. These are more concentrating on leadership, which is wonderful. But the shame is there's still someone who's graduating with a doctorate of nursing practice generally has no more than 1,000 hours of clinical practice. And what's even worse is a lot of these programs have you find your own preceptor. So there are preceptors. There's an interesting nurse practitioner working in our community who's anti-vaccination. And in Washington State, honestly, if you're a pediatrician who was anti-vaccination, I think you'd lose your license. But nobody says a word. And she actively works against people immunizing. And there are doctorate of nursing practice candidates that are sent to precept with her. And they listen to her talk about using goat's milk in babies and breastfeeding exclusively for the whole first year and things that are really not in line with the American Academy of Pediatric standards. So again, you don't even know what training they're getting clinically, if it's even appropriate.
The things that you mentioned sound more like advocacy for this very issue.
That's exactly what it is. And I think what's happened is there's this idea that I think nurses, they wanted some leadership, some people in health policy, some sort of advocacy work. But I think what's ended up happening is a lot of people are clinging to the word doctor. And many advocates will say, well, physicians don't own the term doctor. And that's true. And I like to use Dr. Jill Biden as an example because, there's this controversy about her calling herself a doctor. And to be honest, I don't have a problem with it. She has a doctoral degree. She is not putting on a white coat. She's not wrapping a stethoscope around her neck and walking into a hospital and saying, I'm Dr. Biden. I'm going to be your provider today. She's saying, look, I have a doctoral degree. And again, I think that's fine. It's this confusing part where people who get a doctorate of medical science, that's what a PA can call themselves. They can call themselves, a doctorate of medical science. So after they finish their schooling, they can walk in a white coat and a stethoscope and say, I'm Dr. Smith. And the same with someone with a doctor of nursing practice degree. And the patients don't know.
Yeah. And I think that's from the beginning of our conversation, that's really been your point, is that the patients don't know, and it is our obligation to educate them, or at the very least, to be transparent.
That's right. And I do want to say, I want to be clear, a lot of nurse practitioners and PAs are very clear. So I do want to respect the colleagues who are very transparent. I work with a nurse practitioner and she's a pediatric nurse practitioner. She did go and get her DNP degree and she's very clear that she is a nurse practitioner. And I really admire the way she says, hey, this is who I am. And I want to be loud and proud about that. I'm not trying to be a medical doctor or physician.
Right. One of the issues that I thought was so important in your book was that the traditionally underserved communities are likely to be the groups who are going to take the brunt of this push to use NPs and PAs as the equivalent of physicians.
What's happening is this push towards corporatization of medicine. So a small rural hospital, in fact, small rural hospitals are closing all over the country every day. They don't have the funding to stay open. And unfortunately, even through COVID, the pandemic has really dropped kind of the census or the volume that these hospitals were seeing. So what does a large clinic or a hospital do in a rural area when they're out of money? Well, they go to the next biggest basically buyer. Right now, those are venture capitalists. They are large university or academic hospitals and or other large conglomerate businesses. So then they purchase the hospital and then they make changes to make it profitable. And in order to make rural care profitable, what's happening is they are staffing PAs and nurse practitioners in states that allow independent practice. And, Alexus Ochoa's situation is a perfect example. All of these hospitals owned by the same, Mercy system. I think it's sort of this chess game, let's put one doctor and one nurse practitioner in the ER. And then now let's add a second nurse practitioner for that doctor to supervise. And pretty soon it's 5 nurse practitioners. And then it becomes, let's pull the doctor out of the ER. It's sort of this stepwise elimination of expertise. And what happens, like with Alexus, is this nurse practitioner was all by herself and she didn't know what she was doing. And she didn't even know who her supervising doctor was to call. That's what happens in these, quote, small rural areas. Remember that administrators who are not physicians are going to think about people as widgets. And that's it. And if you're talking about how many widgets you need to get through the door, you don't care if a pink elephant saw the widgets. You just want your money. And that's what's happening in rural communities. It's not about, I'm your doctor and I know you personally and you deliver the paper to my house or you're my plumber. And in town, people support each other. That's not what's happening now because these small hospitals are having to sell to large conglomerates.
Right. And I think in some of the more impoverished areas or in underserved communities, they're going to be the first ones vulnerable to having underqualified people seeing them, and they will suffer the outcomes that can go along with that.
When Arnold Schwarzenegger went in to have his procedure, and I think we wrote about this in the book, we know one of his anesthesiologists, he very much made sure he had physician anesthesiologist. It's so amazing. He signed bills while he was the governor of California to allow the poor, or I like to say who he believes are the have-nots. That's not my feeling. I want to be really clear. But I think the politicians look at it as haves and have-nots. And if you're a have-not, who cares who takes care of you is kind of their perspective. For me, it doesn't matter. It's never mattered to me, your color, your background, your status. I usually don't like patients to yell at me. That kind of makes it an uncomfortable relationship. But otherwise, I'll take care of any human being that I can. And that's a big difference between the politicians. They're not on the front lines. They're not seeing suffering. They only want to say who will tolerate having less high quality care.
I appreciate that you and Dr. Bernard have taken this issue on and made so many of us much more aware. Well, Niran, thank you so much. I've really appreciated all the time that you've given to the podcast and really appreciate your podcast, which goes by the same name. I've listened to a bunch of those episodes, and the book is titled Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. We can let the listeners know that they can reach you at your practice website, Silverdale Pediatrics. Is that correct?
Yes. And then my email, which is my sort of public email, is just niranalagba@gmail.com.
Super. I know that you've also been involved with the Physicians for Patient Protection, and that's physiciansforpatientprotection.org.
Yes.
And we'll provide links to all of those things in the show notes. Any last thoughts before we sign off?
The main thing is it's always okay to ask who's taking care of you. If you want a nurse practitioner, that's great. If you want a PA, that's great too. But I want you to know who you're seeing. So don't always assume someone in a white coat with a stethoscope around their neck has been to medical school, because today that's no longer true.
Thanks so much, Niran.
My pleasure.
Thanks for listening to the License to Lead podcast. Be sure to visit licensed2leadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the License to Lead podcast. Thanks so much, everyone.